Joseph G. McCarthy, and I was born November 28, 1938.
Okay. And would you tell me a little bit about your parents and their names?
Well, I was one of 6 children. I had a terrific childhood, big family. My father's name was Joseph. My mother's name was Eva, and I grew up in Massachusetts.
Okay. Were you one of the early families that came to Massachusetts on Plymouth Rock?
No, I can't claim that. My mother actually is Canadian. She was born in Canada. I think my father was about 4th generation from Ireland.
Okay. And what did he do?
My father worked for a utility company.
Okay.
And I was fortunate because he was able to get me jobs summers in construction through college through college.
Okay. Did you go to college up there?
I did. I went to Harvard, not too far away. I lived in, though, and I did my undergraduate at Harvard.
Okay. Well, let me ask you, would you like to name your children, grandchildren, or?
Sure. I should start
great
with,
if you
I'll
have
start
any.
with my wife first. And my wife's maiden name was Carlin Sloan, and we will celebrate our 52nd wedding anniversary this June. And we have 2 children. I have a daughter, Cara, and she lives in Massachusetts, has a marketing firm. And my son, Stephen, lives here in New York, and he works for an architectural firm. And we have a combined 5 grandchildren, 4 boys, 1 girl.
Now-
It's wonderful.
And how did you meet your wife?
I met my wife at medical school. I came down to what I thought was just going to be 4 years in New York, and I was at Columbia Physicians and Surgeons. And my wife was just out of college, and she was sort of an executive assistant to the chief of psychiatry. And in those days, you'd be fixed up. And I had a friend who was married, and his wife said, I have just the gal for you to be fixed up with. And we had a romance that went very quickly, and we were married in 1964. Wow. So my wife went all through residency and training with me.
Oh, okay. So she suffered all that way, and then.
Oh, and they did suffer.
Oh, wow.
Every other night.
Not like now. Every other
night.
night.
It's amazing.
You're
She
sick. That's
stayed
not
with
my
me.
problem. Get in here.
Yeah, that was it. And
Yeah, school of hard knocks.
yeah, and residencies were very demanding in those days.
Sure enough.
And God forbid you complain. You just grinned and bore it.
What inspired you to go into plastic surgery? And could you tell us about your mentors when you're doing that?
Sure. I went to medical school. I thought I was going to go into internal medicine. I'd won the 3rd year medicine prize, and everyone assumed I was going into medicine. I thought I was going to. And 4th year of medical school, I had a sub-internship in surgery for 2 months. And I recognized that I valued using my hands, and I valued solving problems immediately. And I sort of liked the interventive aspect of surgery. So at the last minute, I switched from a medical internship to a surgical internship, and thought I'd go into cardiac surgery because I could combine medicine and surgery, and did a general surgical residency again in New York at Columbia Presbyterian. And about 3 years into it, I can't say I was bored, because I really learned a lot from general surgery and realized it was making me a surgeon. But I found it a bit algorithmic. In other words, if you have this symptom, you go to this point, and if you have that, and it was almost, well, don't want to use the word ritualistic, but there was a blueprint you followed.
Right.
And I had a rotation on plastic surgery, And I think then I recognized that it was more free thinking, it was more creative. Uh, it left, it let the surgeon approach a surgical problem in multiple ways, probably with multiple types of results. And I decided to go into plastic surgery about my third year of general surgical residency.
It's interesting you say that because people say to me, why'd you go into plastic surgery? You just gave me the perfect answer. Other medicine's algorithmic. You're allowed to be creative. Somebody walks in our office with a specific thing. We see the defect.
Yeah.
We already know that what that result is. In our head, we work backward in our own algorithm of what we can do, but it's not a rule out disease type thing.
Yeah. Well, I always like to say that.
It's reverse engineering.
Yes, I agree. And I always like to say you could give the same plastic surgery problem to 50 different plastic surgeons, and you'd probably see 50 different approaches and maybe 50 different types of results.
Absolutely.
And it's that free spirit I think appealed to me as a young surgical resident. I was very fortunate. I did have mentors. And I've always been fascinated with the whole concept of mentorship. In general surgery, the chief was Frederick Herter. And I admired him, the way he took care of patients. He had a wonderful style in the operating room. And to this day, I'm indebted to him for what I learned. And then I decided to do my plastic surgery with John Converse at New York University. And it was a young program. And in 1969, when I started interviewing, it was not one of the top programs. But I interviewed with Converse, and I was just captivated by his spirit. And I decided to go to NYU. And one of the other chief residents was Henry Kawamoto and at Columbia. And Henry also came down with me to NYU to train with Converse. And I guess Converse really was my big mentor. He was very dynamic, very far-thinking, Renaissance in man in many ways. And I used to say ideas flew out of his head. Let's say 100 ideas in a day, 90 ideas you probably shouldn't pay any attention to, but there'd be 10 beauties among the 100. And he was.
You got to do an algorithm for his ideas.
Yeah, that's right. That's right.
Which one would be the best?
And he had a great sense of history and literature. He was just fun to be with. And I sort of came into plastic surgery residency, even toying with the idea of going into hand surgery. But 3 months into my residency, just a junior plastic surgery resident, NYU has the Kasanjian professorship. This was 1971, and the Kasanjian professor that year was Paul Tessier. And the ASPS meeting had been in Montreal, and they all came back to New York. Tessier was going to be the Kasanjian professor. And Converse chose a 16-year-old girl with Crouzon syndrome, and Tessier was going to do the Lefort 3 osteotomy. And Converse said to me, "Joe, get the OR opened early." So I was able to persuade the head nurse to open it at 7 a.m. instead of 7:30. That's the best a junior resident could accomplish. And the operation began with Tessier doing a Lefort 3, assisted by John Converse, and Sam Hammer, who was another resident with Henry and me. Sam and I were poised at the left iliac crest waiting for the order for the iliac bone graft. And hours later, it came down, 18 millimeters he wanted. Tessier did. So the operation was completed at about 1 or 2 o'clock in the morning.
Okay.
And, that was my introduction to plastic surgery residency.
I'm tired just hearing the story.
And I went home. I don't know if I went home, but a day or so later, I said to my wife, I'm going to be a craniofacial surgeon. And that was it.
Interesting.
And then Tessier said, I really want to come and spend time with you. And he said, he didn't speak much English then. He got much better at it. And he said, but we have to be able to converse in English. So I had to brush up on my French. I mean, we have to converse in French.
Yeah.
And so Converse really was a wonderful mentor.
Well, the next question I have, which is kind of a segue to this, is that we've seen momentous changes, paradigm shifts in plastic surgery during our careers and your illustrious career. And you've just mentioned one. Any other ones you'd like to mention? And they can be philosophical as well as, technical.
Well, I'm at that age where you get very philosophic and historic in your outlook. I think there have been several big paradigm shifts in my professional life. I think one is very broad, and I saw plastic surgery become something for everybody. I think when I went into plastic surgery, it was a small specialty. And I got my board, I finished in 1973 and got my boards in 74. And it took care of some patients with congenital problems, accidents, fractures. Cosmetic surgery was very small then. And it was movie actresses, socialites. I remember as a young attending doing a facelift. And Converse came into my room, and he was looking at the patient. He said, "Do I know her?" And those days, HIPAA didn't mean anything.
Oh, yeah.
I said, "Oh, this is Mary Jones or something." And he said, I think I know her. And I said, "Well, she's a school teacher." John Converse couldn't get over the fact that there was a school teacher having a facelift. And I only tell this story because that's how times changed. Cosmetic surgery, cosmetic treatments of the face, it's for everybody today. So that's been a major paradigm shift. How many people seek plastic surgery in one form or another? Probably that's the biggest paradigm shift in my time in plastic surgery. I think another big paradigm shift was plastic surgeons developed the technology to cover any hole or defect in the body. Not only cover it, but to do it aesthetically and functionally. A lot of that was due to all of the new flaps that were introduced in the late 70s, 80s. A third paradigm shift would be the development of craniofacial surgery, because I think in my professional lifetime, from the clavicles up, we developed the skills to take the face and craniofacial skeleton apart, reassemble it. And I can remember when people feared orbital surgery because of fear of causing blindness, or cranioplasty was looked at as dangerous because of brain injury. And now all those procedures have been refined. And to me, those are the big paradigm shifts in my professional lifetime.
So we've talked about the paradigm shifts and innovations in our specialty. I'd like to ask you what your greatest professional accomplishment is, and you showed me a prototype for facial distractors.
I got a terrific boot out of the work we did on craniofacial distraction. We had been working in the laboratory trying to lengthen the mandible. And we were singularly unsuccessful. And one day the residents took me up to the orthopedic floor at Bellevue Hospital after I'd made rounds with my residents. And they said, there's something interesting going on the orthopedic service. And I went up, and there was a patient lying in bed. I remember he was a male in his late 30s, and he had the Ilizarov device on his leg, and he had had a fracture, and they were lengthening his tibia. And I immediately thought, wow, this is meant for the bones of the craniofacial skeleton. And first of all, it proved one thing: listen to the residents, or listen to people around you, listen to people who are making suggestions. And the second thing is, we did the right thing. We went into the laboratory. And in those days, there were not IRBs. We got some dogs, and Nolan Karp, Charlie Thorne were fellows. And we started using this device on the mandible of dogs. And we immediately recognized that we were onto something, because when we stripped the craniofacial skeleton after sacrifice, we saw that we had generated terrific bone of good quality after biomechanical testing, and also of good volume. So we used this, not this very same, but this model distraction device in 1989, and we did the first mandibular lengthening on an 18-month-old boy with craniofacial microsomia. And incidentally, this patient and I have remained friends. He's now an executive with the football team here in New York, the New York Giants. And of course, distraction has been applied to not only the mandible, the maxilla, mid-face, cranial vault. So you're asking me what I'm proud of. I think in terms of research, this is it. But I have to emphasize, it wasn't just me, it was a whole team. And I think when you look back at your professional life, you have to recognize all the people who contribute jointly to the success of an effort.
Yes.
Another professional contribution that I'm proud of was emphasizing craniofacial surgery on infants and pediatric patients. The generation ahead of me, for example, Converse and Tessier, were not trained in pediatric surgery, or they had not had exposure to pediatric anesthesiology or pediatric intensive care, whereas my generation had. So a group of us, in fact, the person you're interviewing next, Linton Whitaker, and a group of us pioneered a push to get these children operated on at a younger age, so that psychosocially they would do better in school and growing up. So that was another area that I was very proud of. I'm also proud of the educational programs we ran at the Institute at NYU. I was involved in the training of 200 residents and 30 post-residency craniofacial fellows.
How many chiefs?
20, roughly 20 who went on from the training programs to become chiefs of academic units. And you just can't spend enough time with young people. You learn from them, they excite you, and you watch them evolve. So
sometimes you get to watch them make mistakes because they won't listen, and then they learn their own way.
Yeah, and
they're just young enough to think they
I always love the residents who would say in the middle of an operation, "You sure you want to do that?" and as I said, that taking me up to the orthopedic floor that day, and I could have said, "Oh, I have to run to the OR," and But it's not just residents. You've got to keep your eyes and ears open all the time. So, no, I think in my career, the research, the educational program, and of course, the great joy is taking care of patients.
Now, the other side of this is that what do you think the greatest mistake our specialty has made?
Well, I don't know if I like using the word mistake because I am very grateful to plastic surgery. As a specialty, I'm very grateful to the wonderful colleagues I have known. And I really believe in plastic surgery. It helps people. But I think we could have made some moves differently over the years. I think we should have struck out for professional independence much more forcefully than we did. I think we stayed a stepchild of general surgery too long. And I have no axe to grind because I'm boarded in general surgery. You know, you and I both did general surgical residencies. And I think we'd both agree we learned a lot. They made us surgeons. They gave us self-confidence as surgeons. But I think orthopedics, especially, ENT, urology, were smart. They said, we are a separate, independent surgical discipline. Do you know, at one time, anesthesia was part of general surgery departments.
Wouldn't surprise me.
They went out on their own. I mean, just think if orthopedic surgery had stayed a division of general surgery, they wouldn't be the specialty they are today. I think there'd be more independent departments of plastic surgery than there are today. I think that is an area that has to be developed more. The plastic surgery residency should not have adjectives in front of them like integrated, independent, traditional. We should say this is a plastic surgery residency. And just as orthopedics does, we should take the residents right from medical school and imprint on them. I think it's important to imprint on the young residents immediately and not after they've had 3 years of general surgery. And obviously, we've moved much more in that direction, but I wish it had come a lot earlier. And so I wouldn't call it a mistake, but I think the pace of independence could have been more rapid. I just thought of something too. Another interesting thing is when you look at transplantation. Transplantation was pioneered by plastic surgery. Converse had a series of transplantation conferences here in New York in the 1960s. Milton Edgerton attended, Joe Murray did, and of course Joe Murray won the Nobel Prize for the first organ transplant, the kidney, in 1954. I was always amazed that organ transplantation didn't stay in plastic surgery. And again, it was I think that interface with general surgery. And yet today it's back again with the limb and face transplants, which, as my successor at NYU, Eddie Rodriguez, is doing so masterfully. So I think we're headed in the right direction, but we should accelerate that.
Well, I would agree with you. Yeah, anything you want to talk about, I always put this in your greatest professional disappointment. Then I get to the good parts.
No, I don't think I can say I had a disappointment. I mean, there's certain things I wish I had done better or anything, but I tend to be an optimistic person. I sort of lick my wounds and move forward. So I can't say to you, David, that, oh, I wish I had done this or that. And
well, I guess we're the sum total of what we are today because of what we were.
Yeah.
If you change anything, it changes everything.
Yeah, and we had some good luck in our lives, and just think if we hadn't.
Yeah.
Knock on marble.
Yeah. So, what's been your greatest joy? And you can combine that with who do you admire most professionally or personally? Just some final
Well,
thoughts.
I think we live multiple lives as we look back at our lives. We have our personal life, and in my personal life, I'm by far my greatest joy is my wife. We were married 52 years. I'm blessed with wonderful children who I thoroughly enjoyed. We all gathered for Mother's Day here in New York last week, 5 grandchildren, and that's a great joy. Of course, I have more time for my grandchildren now than I did for my own children, so I feel very fortunate. I have a second go at this, and hopefully I'm doing it better. Professionally, my other life, greatest joy, I'd have to put patients up there. You know, it's interesting. I operated on both adult and pediatric patients. I don't consider myself a pediatric surgeon because I sort of look at myself as a regional surgeon because I would say after about 5 years in practice, I only operated on the face, both reconstructive and cosmetic. But I've had the joy of following patients for 30 years. And that has been a great joy. I have many joys in my professional life. The faculty at NYU, and staff, I am forever grateful to. I was impressed that we retained faculty very well. I was the young kid on the block when I became chief, and I mean the support I got was just incredible. So that has been a joy. Patients, staff, I mentioned earlier the residents and the fellows. That has been wonderful. And again, the academic side, we had an NIH grant for almost 20 years, the writing, working with staff on these projects. So been a lot of fun.
Any words of wisdom for present and future generations of plastic surgeons?
Well,
You touched on this.
I'm always reluctant to give advice to the generation coming along. I think when you're a parent, you have to be very careful saying, I would do this, I would do that, but I guess this is an interview. And I think my advice would be general in nature. I think it's very important for people to live their lives fully. And I think if someone has completed a plastic surgery residency, you have hard-earned skills, and go use them. And the converse of that is people who have wonderful surgical skills that can really help people end up really not using them. And I always say, jump in the pond. And I think those are the happiest people, the people who wade in and get involved and not let a business plan direct their lives. And I think that is the most important. I think too, as plastic surgeons, we got to recognize the role of research, because research leads to innovation. And as a specialty, we don't own part of the human real estate. It's the flip side is we can go all over the body and do things, but you know the cardiac surgeons have a flag right in that pump that says we own it. And I think as plastic surgeons, we have to realize our lifeline is innovation and research and creativity.
Any words of wisdom for retirement?
The R word, I call it.
Yeah.
Well,
It's a tough word.
It is. You know,
Don't say it.
Don't say it. And it's a bad word. I mean, it almost sounds as though you've stopped living. I stepped down in 2013, and I had thought about it and shared it only with my wife. I did not want people to be hearing me use the R word. And I stopped very decisively. I went to see the dean, and he asked me to stay on, and I said no. I knew the day was coming, and he said, will you stay until we choose your successor? And again, I said no, because I didn't want to be lame duck while some search went on forever. And I gave him 4 months. And I stopped being the chief, and I stopped my practice. I did not want to practice and not be chief, and I did not want to be chief and not operate. And so they appointed an interim chief, David Staffenberg, and I was very blessed with a wonderful successor, Eduardo Rodriguez. I could not be more pleased. So I'm happy at the way I did make the decision. And then the other aspect of your question is, what do you do once you have all this time? I do not go to rounds. Dr. Rodriguez will invite me to this or that, and I go. But I wanted my successor to have free reign. I did not want to be the old codger sitting at rounds saying, why don't you do it this way? And I've been very active. I still do visiting professorships. I'm almost finished writing my book on distraction, and I am involved on several not-for-profit boards, and we started a not-for-profit organization for burn children. And my big project is starting a museum of medical history and health in New York City. New York City does not have a medical museum.
Interesting.
So that's my big project, in fact.
So you're just making a lot of lateral moves. You're not, it's just where you're going to put your concentration now.
Yeah,
you just don't say I have to get up at 7 in the morning, go to the office. I've got to get up at 7 in the morning because I want to go do this, or this project. You'll probably be busy.
Yes, I think that's the main advice, is stay busy. It may be Brownian movement. I don't know if you're accomplishing that much, but you have to stay busy. And I do spend more time with family. I play some golf. I do some gardening. I'm busy. I'm active.
Okay, so the final thing is, what do you see in the next quarter century plastic surgery innovation or prediction that you might have for where we?
You want me to get the crystal ball out?
Yeah, why not?
Okay. Someone asked me the other day, what was the 10 years in your career where you felt plastic surgery was very innovative and really took off? And I was with a couple of other contemporaries of mine. I won't quote their names, you'd know them. But we all thought the period from about 1975 to 85. That's when flaps took off, cosmetic surgery took off, microsurgery took off, craniofacial surgery took off. For some reason or other, it was a very fertile period for creativity, innovation. And even extending beyond those 10 years, in my lifetime, the specialty changed tremendously. I remember my wife said to me once, "You don't come home with bloody underwear anymore." And I thought, what does she mean by that? And it was a very astute observation, because my wife did not want, maybe you had the same thing, she did not want that in our house. And it was true, because when I think of some of the operations we did and the amount of blood transfusions we did, and at the end of my career, blood transfusions were unusual. That Le Fort 3 with Dr. Tessier and John Converse went, I think I said 19 hours. Well, at the end of my career, I could do a Le Fort 3 using distraction techniques, and start to finish would be 8 hours. And I think that's just indicative of what had happened in the specialty in my lifetime. So that looking over the next 25 years, I think it will be definitely less interventive, less invasive, and it started that way. I think the immune response will lick that problem. And you look at an ear reconstruction now, a rib graft ear reconstruction. I mean, that is a big, multiple staged operation. Even in the best of hands, it doesn't always look like an ear, but there's the possibility of, having a bank of ears and transplanting. And again, a lifetime of immunosuppression won't be as dangerous then as it is now. But I think even more important than transplantation is going to be tissue engineering, what Joe Murray used to call regenerative medicine. I think distraction is tissue engineering, regenerative medicine, where you cut the bone and then you gradually stretch it apart. And the patient doesn't make scar tissue. The patient makes real, robust bone. Yeah. And I would always say to the residents when they'd be helping me do a facelift, I'd say, how many years, when do you think this operation will be obsolete? And the residents would, I don't know, they'd say, and I'd say, well, I'd be very surprised if this operation lasts another 20 years. Because I think what will happen in the future for the aging face is there'll be some solution in a bottle and you'll take a Q-tip and apply it to your skin, and the collagen and epithelium will be remodeled. And you'll probably start doing it in your 30s.
What a wonderful interview.
Well, the pleasure was mine.
What a pleasure to meet you.